Good afternoon, everyone. I see some people are still joining, so I'm going to give it just a second before I get started. All right, good afternoon, everyone. Welcome to today's webinar. My name is Robert Hersey. Happy Wednesday to each of you. On behalf of FATA, welcome to the webinar titled Integrated Community Services, Keeping Children Out of Higher Levels of Care. This webinar is being made available through a collaboration between the Florida Department of Children and Families and FATA. Please note, as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them using the chat panel as you think of them. We will track questions and answer them as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any time during today's presentation, there are a few options to try using the audio connection panel. For computer audio, click the up arrow next to Audio Settings, click Leave Computer Audio, click Join Audio, click Join with Computer Audio, and follow the instructions. If you continue to experience poor audio through your computer, try calling into the presentation. Instructions will be posted in the chat panel momentarily. You must be connected to the audio of this presentation and view it on screen to receive a certificate. We cannot verify your attendance if you are not connected to Zoom through the website, desktop application, or mobile application. Therefore, phone call only attendees are not eligible for a certificate of attendance or CEUs. The recording materials used in today's presentation will be available on the FATA website within 30 days. To access the recording and PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. A certificate and CEUs for up to 2 continuing education credits are available for participating in today's webinar. CEUs will be available for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for those credentialed through the Florida Certification Board. To receive a certificate and CEUs, you must attend the entire webinar. Zoom provides a report of the arrival and departure times of attendees. We are not permitted to provide partial credit. You must also complete the post-webinar evaluation. The evaluation will close on Monday, February 16th, 2026. Certificates will be distributed within 30 business days after the evaluation closes. CEUs will be posted within the same time frame. If you are out of state and licensed and looking for CEUs, you may use the certificate to report your CEUs to your licensing board. FATA has implemented operational changes to our webinars based on the feedback of our attendees. Below are a few important changes. Evaluations will now take place in Zoom immediately after the webinar ends. Certificates will be emailed to you directly. You no longer need to sign into your FATA account to complete evaluations. For all webinars and workshops November 2025 and later, certificates will be emailed to you directly. For webinars and workshops before November 2025, certificates are still accessible through your FATA account. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenters and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, FATA, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. Our presenters today will be Lyanna Alvarez and Emily Jones. Lyanna has 10 years of experience in the behavioral health field and earned her master's in school psychology from Carlos Albizu University. As a senior clinical program manager, she oversees various grant projects in Seminole, Orange, Osceola, and Brevard counties and helps guide and support clinical staff and managers in their work. She is currently pursuing her PhD in social work, focusing on managing social programs and policies. Emily is a registered clinical social work intern and has been in the field for nearly 13 years. Emily graduated with her BSW and MSW from the University of Central Florida. She has served in various roles, including therapist admission specialist, targeted case manager, and clinical liaison. Currently, she is the clinical manager for the Orange County CAT team. And now I will turn it over to our presenters, Lyanna and Emily. The floor is yours.
Thank you so much, Robert, for that wonderful introduction. Hi, everybody. My name is Emily Jones, and I'm really happy to be here with all of you this afternoon.
Hello, everybody. Thank you, Robert, for that introduction as well. My name is Lyanna Alvarez. I am also with Aspire Health Partners, and we oversee the programming for the CAT teams over here, as well as other programming which includes FIT, DOT, and TREE programs. So really happy to have you all here for this lovely webinar.
Yeah, so we'll just go ahead and just jump right in. As Robert stated, if you guys have any questions, go ahead and field them to the chat, and we'll get to them as we're able to. And thank you all for attending today. All right, so today we're just going to talk a little bit about integrated community services and how, as a program and as an organization, and as part of the Florida legislature, as you guys will soon hear, we are trying to help keep children out of higher levels of care, and we're quite successful.
Alrighty, so some of the learning objectives is going to be describing the CAT model. I see that a lot of you guys are from different CAT teams with around the whole state of Florida. I see people from Tallahassee, from Brevard County. I see people from all around all the other CAT teams. So we're going to talk a little bit about the CAT team model and what does that entail. We're also going to analyze some of the data that we have achieved throughout the last fiscal year, which will come with some case examples that we're going to be sharing with you guys about all the wonderful things that here that we're doing in the Tri-County area. And we're also going to talk a little bit, and we have an activity at some point with that during the presentation where we're going to be talking about some activities that we can integrate within our data information and our performance and measurements that we do for our CAT teams.
So kind of just to support what Lyanna just said, a little bit about our agenda today. So today we're just going to kind of give you guys a high level overview of what Aspire Health Partners is, who we are within the community, and all of the services. Well, again, very high level, all of the services that we do here at Aspire and that we provide here at Aspire, as well as kind of the history, a little bit of history and definition of the CAT team. Going over, like Lyanna said, some of our data and our outcome measures from the last fiscal year, as well as integrated program strategies in terms of what we do. And again, to back up what Lyanna said, I see also that we have a bunch of CAT teams represented. So hey, shout out to the CAT teams. But also, some of the integrated program strategies that we use here. And kind of a Q&A here at the end with a little bit of an activity for you guys to start thinking about and generating your own ideas in terms of strategies that may work for you or that don't work for you as well. And then of course we'll finish things up with our contact information, for you guys to reach out at any time.
A little bit about Aspire. Aspire Health Partners is one of the largest nonprofits here in Central Florida. We have services stemming from inpatient, residential, community-based, outpatient services, case management, you name it. We have a lot of services throughout our county. We serve people from birth to geriatrics. We serve the Orange, Osceola, Seminole, Brevard, Lake, Hillsborough County. We currently have 90 psychiatric specialty beds, 87 CSU beds and SRT beds, 40 inpatient detoxification, as well 160 residential beds for adults, 26 for adolescents, and 271 supportive housing beds. And more upcoming in the future. Aspire is ever growing and expanding. So that's something to say about our organization, which is a big, big shout out that we have here. And we are proud to have CAT teams within our Seminole, Orange, and Osceola County, and that's kind of where most of our information was. We're going to be talking on today.
Yeah, so one of the pieces too with the community-based part of what we do, a lot of our therapists are contracted with various schools and school counties that we are in. to provide school appropriate counseling and therapy services within that kind of forum. So just a little bit of a history and a definition of the CAT team. So some of you might know, but the CAT team actually stands for the Community Action Treatment Team. So back in 2004, the first CAT team was ever was implemented in Manatee County. So if any of you folks are here from Manatee County CAT team, like huge shout out to you guys, because that is where CAT team was birthed. So they received special funding for this one particular program to see if those outcomes would deliver. And they did between 2010 and 2012. They found great success at keeping kids out of, in fact, higher levels of care, and more manageable at lower levels of care. And then, as we know, in 2012, unfortunately, they were hit with the Sandy Hook tragedy, which kind of helped spur them on to continue with the funding and with this idea of the CAT team. And so the next year, in 2013, throughout the state of Florida, they implemented 9 more teams. So by the end of 2013, there were 10 CAT teams across the state. And again, in 2018, unfortunately, as CAT team was kind of building momentum and growing, 2018, unfortunately, right, we were hit with the Parkland tragedy, excuse me. And then in 2019, continued to grow. We hit a staggering 41 CAT teams within the state. And then by 2021, every single county within the state of Florida has a CAT team. And again, CAT team was written into the Florida legislature. So you can find us, all of the way that we run, the way that we're supposed to run, and we'll touch on that here in a little bit as well. But all of those things, they have found great successes in, and
And to add into that is something important to also know is that there's a specialty map within the website of DCF that also has information regarding our CAT teams and all other programming within the state of Florida. So we also have the MRT program, we have the FIT programs that are listed. So there's a specialty map that you can actually access information and contact information for all of the other additional CAT teams. So the CAT team is a multidisciplinary community-based group that offers intensive wraparound services to children, adolescents, and young adults at risk of being placed out of home due to mental health and or substance use disorder. We colloquially call it Hospital Without Walls. This is something that from other presentations that we have heard, meeting with other managing entities, this has been like the common knowledge of our programming is the Hospital Without Walls. We serve clients in the community. We go to clients' homes. We provide all services within those spaces, and we maximize service accessibility. I think that's something very peculiar about the CAT teams, very similar to what the ACT teams across the states and across all of the nation, because not just us here in the state of Florida, but it's nationwide and worldwide, where the ACT teams actually come from and stem from and replicated that for children and adolescents. So something about the Hospital Without Walls, I first started in that setting. I started being that counselor, and then I moved on as the lead therapist, management, and now I'm in senior management now. And I can tell you the greatness about being in the CAT team and being able to not just hear clients coming to my office and telling me, hey, this is what's been going on in my home, or this is what's been going in my school, this is what's been going with my probation. It's actually being there with the family within their homes and supporting them, not just from counseling perspective, but from case management, from mentorship, from medication management, to all their other services that we're going to be talking more in details in just a few more minutes.
Yeah, absolutely. And just to, again, back Lyanna up, the idea of a hospital without walls is really accurate, especially with the CAT team. So, DCF has published the Guidance 32 document. And this is the standardized document under which all of the CAT teams throughout the state of Florida it's kind of like a handbook as in terms of how we're supposed to run. And, it kind of just outlines our staffing patterns and the services that we are to provide and, things like that. just as like a frame of reference and a guidebook for how we are to provide services. So within the guidance 32, which you can easily find online, and we have some links at the end of the presentation as well that can take you there. But in the guidance 32, it does outline the criteria. So because CAT team is not traditional outpatient, and obviously we are in the community, so we're not inpatient, we're not SRT, we're not residential or any of those things. We're kind of like almost like a non-traditional IOP. So we are an intensive outpatient program without being the IOP. So because of that, there are certain eligibility requirements that the kiddos and folks that are coming onto the team have to meet, because we do deal with the more kind of like chronically, mentally unwell kind of folks. So eligible kiddos who come onto the team have to be anywhere from 11 to 21. Now, that's not to say that we won't take somebody who's younger than 11, as long as A, they're meeting more than one of our criteria, and B, we're able to kind of assess and confirm clinically that we believe that they could probably make these changes and have the psychological bandwidth to understand and participate, engage, and benefit from our services. So that being said, as well, they also have to have a mental health and or substance use disorder diagnosis. So we do a bit of, co-occurring disorders as well. So the substance abuse, generally from what we see, at least here in Orange County, is that we will take those kiddos with substance use disorders kind of as like a secondary. So generally speaking, the primary diagnosis that we're looking for is a mental health diagnosis. So the CAT team in general is just designed to be a short-term, super intensive program, usually lasting about 6 months. And one of the things in the guidance document that I love, that I remind my team of probably on a weekly basis, is that we are to provide services by any means necessary. And I really feel like that is the heartbeat of the CAT team, is that our service provision happens by any means necessary. So we are, because of our funding, we do have a little bit more wiggle room in terms of being able to provide these services by any means necessary. Typically, we aren't waiting around for TBOS authorizations or, targeted case management authorizations to go through insurance companies to expedite services or increase service provision or things like that, where as long as we're able to clinically justify that and help move kids out of these crises, then, by any means necessary, we will do that.
Yes, and something about our programming is so when what we're presenting currently is the traditional CAT team 11 to 21, and I think is our next slide. So in our next slide, we're going to talk about, like, we have different models. So at least in the Tri-County area in Orange, Osceola, Seminole, and Brevard, which also is part of our managing entity, we had the traditional tier 1, what we colloquially call tier 1 CAT team, which is the 11 to 21 years old. And then again, like Emily was saying, yes, we do have that any client that is younger than the age of 11, meeting that criteria. Usually we consult with our psychiatrist in our agency. The teams consult with me to see if they need clinical criteria to make sure that they're appropriate for our level of care, and that we can provide additional service. I think the biggest part of it is the services are provided under a grant. So services are free of charge for most of the families that we serve for the majority of the state within our CAT teams, with minor exceptions, but they're so minimal that we can actually find additional fundings and sponsors for additional services like medications that they might have that are not covered within their own medical insurances, but other services that are within our umbrella are fully covered completely by our CAT teams. And it's not just the counseling. I think also adding the added component that when we're talking about counseling is our program has case management and all the other services, which we'll talk in just a few more minutes to give you more an idea of how our staffing looks like. But it's not just the counseling, it's added components, because these the families that do come to be served within our clients have a lot of additional needs, not just the counseling need, they have additional needs. So within the additional guidance documents and within the DCF website, for the managing entity, you're going to be finding additional programs. One is the FFPSA, which is the Tier 2 Family First Prevention Service Act. We also have the Tier 3, which we colloquially call it Baby Cat because it's for the ages from 0 to 10. And then we have Tier 4, which is the FST programs, which is for the most intense cases that we have that we clinically determined to be in a Tier 4. Bear with us that those teams that because they're actively within the managing entity, that doesn't mean that they're fully active in all counties. So the only one that is actively in all counties will be the traditional 11 to 21 CAT team. The other CAT teams might be sporadically serving maybe 1, 2, or 3 counties in those areas. So when it comes to that, those additional tiers might not be fully serving the county that you're residing. However, there might be an expedited for another county to be able to provide services depending on how large the county is. Because I know some counties are a little bit on the smaller side, some counties are a little bit on the larger side. So understanding that, if for example, the baby cat might not be in the county. For at least for our counties, we don't have a baby cat, for example. That means we might have to identify other resources within the community or their programs that could meet that criteria for something similar to a baby cat. So those will be in all of those will be in the specialty map website. So you'll be able to see all of these programmings within there with their contact information, which is for me one of my best tools whenever I have clients that get referred here, and they tell me, oh, I heard about the Tier 1 or Tier 2 or Tier 3, and I tell them, okay, let me just send you the information about the specialty pharmacy so you can reach out directly to that agency that might have the service that I currently don't have here, but it's always serving the community to make sure they have the services they have.
Yeah, and I think there was a question in the chat for what counties are in Tier 3. Here at the end, when we give you some links and some resources on CAT team in general, it will have that map that Lyanna is talking about. So you can actually go in and physically see for yourself, and it'll list the contact information for those counties that do have and provide that Tier 3 support. And again, the 11 to 21, again, we're as a Tier 1 provider of CAT team, we are not hard and fast on that, on either of those age limits. Again, if we really think that a kiddo could benefit from us and our services, and they're meeting criteria, the only caveat is that they do have to meet more than one of our criteria, which we will go through in just a little bit, what our criteria is. Well, I can just run through that right now with you, actually. So our criteria are that our kids have to have 2 or more inpatient hospitalizations within 6 months. So that can be a Baker Act, that can be a voluntary hospitalization, that can be residential care, that could be short-term residential, it could be any of those things. It could be even coming out of an IOP or a PHP in the traditional kind of senses. What we're also looking for is there any DCF involvement? If there's an active DCF case, that's an automatic yes to CAT team. Is there any DJJ, Department of Juvenile Justice? Have they been arrested? Do they have a juvenile record? Again, automatic yes to CAT team services. We're also looking for, have these kids tried lower levels of care and been unsuccessful? Have they been in outpatient therapy traditionally for the last, I don't know, however long, 3 months, 6 months, year, 2 years, 5 years? Is it not working? They've tried medication management, all of those kinds of things. So lots of failures at lower levels of care. Because again, we are a step down program from those hospitalizations. So it stands to reason, right, that we would be a step up from your traditional outpatient levels of care as well. And then also, are they at risk for failing school? Are they getting excessive suspensions? Have they been expelled? Do they go to alternative schools? All of those things are requirements and kind of prerequisites that we are hoping, not that any kid has to go through that, but those are the things that are bringing them onto the team, and why a wraparound model is so important, that we wrap that family and that kiddo in services so that the hope is that we heal them from the inside out so that they can go back to mainstream school. They can get off of probation. We can keep the family together by providing parenting support, external resources. Maybe mom and dad also need mental health support, and nobody has ever, crossed that bridge with them. So really just keeping families together, as well as, making sure that these kids are getting the services that they need, to keep them in lower levels of care and functioning at, their baseline. So a little bit about our staffing, again, as kind of dictated to us by our Guidance 32 document, that is amended and kind of refreshed by DCF every year. And as some of you might know, our fiscal year actually runs from July 1st to June 30th. So every year, the new and updated revised Guidance 32 document is coming out. Probably we're starting to hear about little changes or things that might be coming down the pike, probably sometime in June, and then usually close to that July, August timeframe is when things are finalized and they're like, yes, this is how you were to operate for the next fiscal year. And to keep in mind too, there's not usually like gigantic, humongous changes that are going to require, these, what's the word I'm looking for? These big changes in staffing or, things like that. But a word on staffing. So right now, the guidance document is dictating that most of our CAT teams are to be providing services to 30 kiddos a month. 30. Now, you might look at these numbers on the screen and say, wow, 30 kids, that's not a lot of kids for all of these staff. I'm sure you might be right in a traditional kind of outpatient sense. Here, when we're dealing with kids like we just talked about, who have these significant mental health issues and they've failed at every other lower level of care, they are really needing that intensive support, which is why they've come to us in the first place, right? So there are some organizations that have what is called an expansion. And so the expansion might dictate that that specific team might have 40 clients to serve every month, or 45 to serve every month. Some counties also have 2 CAT teams. So the need is so great in specific counties. Shout out to you, Brevard. So, the need is so great and they do such great work with their CAT teams and the outcomes are undeniable, that they receive funding for additional CAT teams. So they might be serving 30 clients per CAT team, or each CAT team might have that expansion. So each CAT team might be serving 40 clients. So one organization, or, depending on the county, might be, dispersed into a couple of different organizations managing, 3 or 4 different CAT teams for the one county. But as it is right now, and as it stands right now, the staffing pattern that we follow is that we have 1 leader, 4 therapists, 3 case managers, 2 therapeutic peer mentors, 1 psychiatrist, 1 nurse, and 2 supportive staff. And I love the idea of this supportive staff because it kind of lets each county tailor the demographical needs to what the demographics need. So it helps everybody in getting exactly what they need, hopefully providing that comprehensive level of care, right? Because as we know, especially in Florida, things happen, right? So for example, I'm thinking like hurricanes. So, hurricanes can really affect the panhandle, but they're not so bad here. So maybe some of the supportive staff are people who have better experience in providing that kind of crisis management care or have that expertise. Things like that, things that are just really, really, really driving home that community-based idea and that community integration. I also sorry, Lyanna, go ahead.
No worry about it. But I did want to add, because I know we see the numbers here for our staffing patterns, and I want to make sure that this is something that for us this is for the Aspire CAT teams. Like this is where this is the amount of staff that we have for our clientele. With the add of the support staff, because I will huge shout out to Emily, because that is tailored specifically towards each of the county, like we can have a court liaison, or we can have an educational liaison allocated to that support staff that would help and support in that sense. For example, we have here in our counties, we have wraparound and we have parent coaching. So we have two additional support staff, one that caters to each one of them, that manages what our needs here in the Tri-County area is. So it's more so until that staffing pattern is geared towards what we need in our areas. And for, yes, we have a little bit of a shorter staffing in a traditional outpatient setting. It might look, oh my God, we have such a little staff for such amount for the amount of clients that we serve. To the idea that most therapists under our programming either see clients one or twice. They might see a client 3 times after a bake crack. The mentors might see the clients in the afternoon and see them in the morning. So and most of the mentors that sees the clients, it depends on what situations we have, but we try our mentors for that area of the client can get a breather, can get that enjoyment, can have some activity to do for themselves, find something in the community that they're looking for, that they're might not do in a traditional setting. They might not be able to find it. And mentors kind of guide that process for them. Case managers might be working on with the family on housing, which, as we know, housing is one of the most complex things that we have here in the state of Florida. Or they might be working on a SIP application. Last week, I was actually working with one of the case managers in Osceola County, working through that process of getting a SIP application submitted for a client, and those takes time. Like that might not be the one time a week or one time a month as a 65D will entitle for case managers to meet with the families. It might be a little bit more so times that the team members get to see the families. So I would say just as a shy number, we see clients between 5 all the way to 10, if not plus hours on a weekly basis per client. And we make sure that, that the staff has all the support and all the guidance needed for any kind of training or any certification that they might need. Because I know some places they might require additional training and support, which is where we are here for. And I always extend my hand to all of my staff to make sure that, oh, wait, there's a training for trauma. Let's go for that because there's a high need for trauma care. There's a need for peer support. Let's go for that. Let's go for certification. I know the FADA and other organizations have had the opportunity to provide some trainings for our mentorships to get certified as peer support as well. So that's something that we also aim for and strive for. It's not part of the guidance, not a requirement. However, it is something that we strive for to make sure that all of our staff know that these resources are available.
Yeah, and sorry, I was just going to say a quick word about the mentors. Like Lyanna stated, they are not certified, and we do kind of vet the mentors to, it's kind of one of those tricky things to answer the question about lived experience with our mentors. So that's kind of like, that's one of those things that's, during the hiring process, we may kind of skirt around, in terms of what we're legally bound to not ask, and those sorts of things. But our mentors are vetted. I know here in the Tri-County area, they are interviewed at least twice, as well as, with the leadership team, as well as with the entire CAT team that they're coming onto, whichever county, to see if the vibes are right? Because the mentors sometimes, it is truly my belief that mentorship and the mentoring that can be provided through CAT team can really be, so profound to so many of these kids. And I think probably many of you would agree. And so really we're looking for those feels from our mentors, and if they have lived experience that they're willing to share, then that even sweetens the pot.
And something I do want to add, because that was when we first started this presentation during the Behavioral Health Association, the BHCon Behavioral Health Conference last year, I had the privilege to meet with Melissa Larkin, which was one of the first people that initiated this whole process of CAT teams across the whole state of Florida. And she highlighted that aspect of the mentorship. But she said that's the backbone of CAT team. Backbone of CAT team is the mentorship, is where the kids get the most benefits from. The kids actually engage in services when we are, as counselors and case managers and the other providers within the team, have the difficulty to engage. The mentors just come in, do a great job. And I can attest that all of our mentors that we currently have, one of them is missing me. That he said that he was going to take me to play basketball. I'm waiting for that one. But they do a fantastic job to highlight with the clients and make sure that all the skills, strategies, and the stability is translated out there in the community. And I think that highlights and shines. And I would agree wholeheartedly with Emily, with Melissa's comments on that. That the mentors are the backbone of CAT team, and they do such a fantastic job. It just makes such a huge difference. As a clinician myself, I can do and be with a client for an hour, 2 hours doing a whole session, and not being able to have that ability to be there with them, which I can do, but with the limited time that we have within the counseling sessions, mentors just come in and do that extra added component to that service itself, which is one of the most fantastic things that I can surely say.
Yeah, yeah, I agree. I think if I can just tell a quick story about mentoring experience that one of my mentors had, maybe like 2 weeks ago or so. They had a kiddo. They took them out, and they had decided that they were going to go window shopping. This kiddo loves to go window shopping. He likes to be out and about and walking around and socializing and those kinds of things. Now, this is a kid who, when he came to us, he was, being hospitalized, probably 3 or 4 times a month, and making lots of just poor choices. So our mentor took him to, I believe it was like Five Below or something like that, and the little boy started talking, after a while, after they had been there for a while, he started talking about, how he comes from a long family of thieves. So, lots of theft and burglary and, things like that he's always grown up with. And that, he started kind of like boasting to the mentor about, oh, I bet that I could slip this in my pocket and I could walk out and nobody would know. And so my mentor was just like, you could do that, and kind of just reinforced pros and cons, right? Reinforced the things that he's been learning in treatment, reinforced, just that positive role model, explaining to him, real life kind of situations, like, yes, you do have that free choice, but there's consequences. And those consequences start here with me, the mentor saying, because I have a responsibility to not let you do that. And I would tell the store associate or whoever, and so you could kind of see the wheels in this kiddo's head kind of turning. And, obviously he made the right choice and was like, I wouldn't do that anyway. That's the old me. But that is just, mentoring. That is, for me, that's the heart of mentoring. That is what mentoring is. It's that positive role model. It's that positive reinforcement to everything that they're learning in treatment and they're seeing in real life, in real time. And then there was something else I was going to say, and I forgot what it was.
It will pop in at some point. So some of the services that we have in the academy, at least in our area, just to highlight again, services are listed in the guidance document 32. At the same time, there's some services to locations that might not be a possibility. But some of the services that we provide here at Aspire for the CAT team is collaborating among a multidisciplinary staff through weekly consultations. We do actually do 2 weekly consultations, one for medication management and one for staffings. We share caseloads and support families. We assess and recommend levels of care. Sometimes we had to either decrease services or increase services within our continuum of care. Minimizing transportation, I think that's my biggest hype is the accessibilities of services. There's some families that live in areas that they might not have transportation, that they might not be able to attend to a mental health facility. Therefore, they cannot access services. So I think that's something also to say about the services we provide. As usual, therapy, case management, and I'm going to skip this one because I want to talk a little bit more on behalf of this one. But mental health and substance use treatment within our services, psych education, mentoring, and medication management. The more response teams and our agency caters towards our crisis intervention. So they do that part of that added component that we used to do it back in when I first started in the CAT team. The funding got reallocated within our mobile response teams to actually cater to the crisis responses. So that's something that our agency has been able to manage and establish. So that's something that I say that I work in the same space and office that the MRT program is currently. So they do respond to calls 24/7 and go out as needed. So they do respond, and they actually collaborate with our behavioral with our BRU units here for the Orange and Osceola and Seminole Sheriff's Office to also respond to some of those crisis calls. Added to that, something that we did want to talk about was the linkage of services. I know we have in our guidance document that we have added services as care coordination, crisis intervention, mental health substance use treatment, psych education, respite care, and transportation assistance. We do have these services. Again, it goes into budgeting and funds available for these type of services, especially for respite care. Since our organization we have our program for CAT team working at latest at 7 p.m. We try our best to work in the respite care and provide that service linkage, but also to provide that additional resource needed for the family to make sure that that aftercare of services that they can receive the respite care. Psych education, we always connecting families to different events and venues across the whole Tri-County area, which, Central Florida Behavioral Health does a lot of webinars and workshops for the families. Deborah does a lot of that as well. So we make sure that we provide those services and all togetherness to make sure that the community is fully served. So the respite care in itself, it's mostly out in the community or in the client's home. So we try to provide as best as we can. Obviously, we don't do overnights because we don't have the staff capacity to do so. But if needed, we also partner with the youth shelters to make sure that if that's something that's needed, that we can actually provide that additional care and service within our continuum of care. Alrighty, and let me see where we at on this. Sorry. Alrighty. So we're going to take a 5-10 minutes break, and we'll be back in just a few minutes. And we'll continue our presentation. So stay tuned, and we'll be back in just a few more minutes. Okay. Hey, welcome back, everybody. So we're going to go into just about two or three questions on the chat before we go into our next topic, which is one of my favorite ones because it's the data one. I love love me statistics and the data that we actually pull from the CAT teams. But I have one question here. How do you serve families that do not want outsiders in their homes? And um, at the beginning, when I started CAT teams and community-based programs, I actually started in the state of Massachusetts as a community-based therapist. And that was one of my biggest questions is how do we engage families that don't want strangers in their homes? There's many ways. One of the biggest ways for me is, we always offer availabilities. So if we have office availability because they don't want strangers in their home, we can always provide that office availability with the expectation that services are provided within home. And we move from there to the client's ability and comfortness. And I think that's something that I've done myself in many instances where maybe they just don't feel like they want people in their homes. So which is and it's a scary situation. Acknowledging that part of that, it is a scary situation for many individuals to have some strangers, and more often these are referrals that come either from DCF, DJJ, so they understand like there might be other added caveats to that process, and acknowledging those with the families and letting them know that we're here to support them. That the primary purpose of our services is not to penalize them or weaponize them in any means or way, is to provide services within their home so they have access to those services that in other ways they would not have them within their homes. And I think that's something I myself work with families if I'm seeing clients firsthand. So that's something I would do.
Yeah, I think too, the nice part about being community based, excuse me, is that we're just that. We are community based. So if there is a family who doesn't want us in the home on a regular basis, every week, then there's not, and let's say there is an office availability. One of the choices and the opportunities that we have is to be in the community. We can go to a park, we can take mindfulness walks, we can meet. I know that sometimes our case managers, might meet a parent, on their lunch break at work, or things like that. And as long as the family is comfortable and, we can make sure that there's a level of confidentiality and trust, within that relationship and what's going on externally. We do have so many opportunities for those folks that don't want us in the home, but it's also, it does put it on our radar. I would be remiss if I didn't say, if a family is that adamant that they don't want us in their home, it's a bit of a red flag. And so, it also, helps us understand kind of bigger picture, what systems might be at play, potential risks and potential threats, both to our kiddos as well as to our staff, of course. Brianna, you mentioned that, even for the service providers, yeah, for sure. There's a lot of folks who are not comfortable, and I'm sure we've all had interviews for, varying positions on our teams and within our organizations. For those of us that are community based, who, when they find out that this is a community based role, they're like, oh, okay, never mind. So, as a caveat to that, I do think that, it does take a special kind of clinician, case manager, mentor, team and team of professionals to, have that level of comfort to go in the home, to, kind of assuage their own fears and their own anxieties about going into the home, with kind of this one track mind of by any means necessary, I'm going to try to do what I can for this kid or for this family. That was a great question.
Another question is, do you work with youth transitioning from SIP placements? This is one of our, if not our top is priority when it comes to services. So we have many kids that are coming for residential SIP placement and they're stepping down. We usually coordinate those step downs with those SIP placements and make sure that those transfer over. We partner with many of them and we actually conjointly work to make sure that whenever that discharge transition is happening, that the CAT team is here to receive them. Same thing goes with priority placement on CAT team to CAT team. When we have CAT teams, clients are moving from one county to another. We don't want to have that interruption of services. So if we have a client moving from Volusia County or from Miami-Dade County and they're moving into Orange County by all means, or Osceola or Seminole County, we take priority to make sure that they're transferring from those placements and they're actually continuing services, and there's not, to the best of our ability, to have the bare minimum interruption of services. If that's a week because they're moving back into the county or they're working in that process and they're still, identifying the caveats within the placement, the residential, because that could be sometimes an immediate week from now discharge, and the family just trying to figure out how to pick up, how to transfer back to the home. They might need to do some grocery shopping and making sure that all those things are happening. So we make sure that those things are happening, and we are in constant communication with the SIP placements to make sure that those are happening.
Yeah, and just kind of to piggyback on that, as far as SIP placements go, it's kind of a two-way street. So generally speaking, the way that it works I can only speak for Orange County for this exact moment. But for the way that it works in Orange County is that, I'll get the referral from the SIP placement, with a tentative discharge date. Typically, the SIPs are sending me referrals for their discharges, probably about anywhere from 3 to 6 weeks before the kiddo's discharged. We have the opportunity then, one of the things that I like to do is I like to be present during their final treatment team at the SIP facility so that I can at least be over the phone, to introduce myself and introduce our services. Most likely by then I've spoken to the parents already to, introduce myself and our services, but just also to just say, hey, we are working together. We are a community, and everybody is rooting for this kid's success and this family's success. That's always kind of like our driving factor. But like I said, it is reciprocal, because in that same way, when we do have kids that, we are moving into SIP placement from CAT team, as it stands right now for us, we are keeping those kids on our team. And we're keeping, while they're in SIP placement, we are keeping in contact with their family. We are, getting treatment updates from their providers at SIP, and we are there to re-welcome them back onto the CAT team, formally, as soon as they discharge. And when we do have a SIP discharge, like I said, since we know about it weeks and weeks in advance, it really helps so that we can plan that out so there is no lapse in services. The kiddo, we did an intake back in November. Kiddo discharged on the 6th of November, and we did his intake on the 7th of November. So it's really, the turnaround time is with the planning and the collaboration and the working together and the openness for service, provision and service reception. With all of those things in place, we're able to kind of, again, keep with that wraparound model and keep that family really tightly wrapped and that kiddo really tightly wrapped in those services so that they can have a more successful transition. And that doesn't just go for SIP. That goes for, not all of our population is, Medicare, Medicaid served. We do have a fair amount of kiddos on our team, currently here in Orange County, at least, that are privately insured. So even those, shorter term residential stays at, your kind of local residential hospital or out of state or something like that, generally speaking, somehow the families find us, or a service provider that they have has found us, and we make contact. And so we're able to kind of have that smooth transition from residential services, however short term, into CAT team services. So yes, we definitely work with SIPs. We really enjoy working with the SIPs because, it's such a high need, especially for more intensive services. Great question. Thank you.
So we'll continue more in the Q&A. We do have a Q&A portion more so towards the end of the presentation. So I'm writing down some of the questions here. Once we get to that point, we're gonna read. I'm gonna read some of the questions. I'm gonna answer the most I can, obviously with time permitting. Further, we're going to continue with the presentation on data and outcomes measurements, and I subtitled this section what we see and kind of like what we saw during this last fiscal year. So this is just data from our prior fiscal year. So it's not our current data from our different performance measurements. That goes into our NICFAS assessments, our days in school, days in community, our CFARS assessments. How are the clients doing and faring as each county and also as an organization? Schools, something I do want to highlight about schools, you're going to see them on the lower range for the reasoning that after COVID-19, many of these schools, a lot of kids transitioning into virtual schools, so that has impacted significantly school attendance, and we still see some of those ramifications from COVID-19 to this time. You know, we're in 2026, and restrictions have been lifted across the whole nation. However, we still see some of that ramification from that time frame. Within our population, we have a lot of clients that either are truant or are not attending school, even though they're enrolled in school. And we can see them in the data that we collect on a monthly basis.
And so just to piggyback on that for the performance measures, those are the 4 areas that we report on every month, that kind of show our outcomes, that show kind of what we're doing and how we are managing to keep kids out of lower or higher levels of care. So we are reporting days in school, you know, like I said, and all of these things are kind of directly correlated to the criterion that you know, these kiddos have to meet in order to join CAT team in the first place. So we're looking at school days. You know, if there's 20 days of school available in a month, how many days are being attended? Not only by that one child, but as a whole team in general, between 30 and 40 kids, 60 kids, 90 kids, however many those CAT teams are serving. On the contrast to that, you know, so when we look at days at school, we're looking at, are they skipping? Are they just flat out refusing to go? Are they getting suspended, out of school suspension? Because all of those count as days not in school. Now, similarly, we look at days in community. You know, again, tracking. Have they been Baker acted? Have they been hospitalized? Are they arrested? Have they been temporarily removed from their family's care? So if there's, you know, February is 28 days. Of those 28 days, how many of those days were those kiddos at home, living, not in the hospital, not in JDC, not, you know, at an aunt's house in, you know, Timbuktu or wherever you want to, you know? So how many days are those folks actually still here and maintaining that kind of baseline and hopefully improving in their symptomology? The NICFAS is the North Carolina Family Assessment tool that we use. There are several domains for those of you who are not familiar with the tool. There are several domains that we are looking at and giving a score based on lots of different criteria. And so one of the main pieces that we look for in the NICFAS in terms of our reporting outcome measures are the child or the youth well-being. And the scores range from -2 to 1, so positive. So +2, +1, +2. and so you know, most of these kids are coming to us, I'm sorry, -3. So -3, we'll have a lot of kids come to us at -3. When they leave, they're functioning at what we would call a baseline at 0. So we're constantly looking at these domains and these criterion within the domains. Yeah, as far as I know, Heather, the NICFAS is used by at least our managing entity. I am not 100% sure on the other CAT teams throughout the state. Lyanna might know, but I do know that at least the NICFAS tool is being used by Seminole, Osceola, Brevard, and us here at Orange.
That's one of my questions that I wrote down. So when we get to the Q&A, I'll give you more information, Heather, because I know other within our guidance document there's other assessment tools that can be utilized, but that will be at the discretion of the managing entities within the area. But for the most part, at least in our Tri-County area, we utilize the CFARS, NICFAS. We calculate with the schools and with the Baker facilities the days that clients are attending school and days that the clients are out of the Baker facility or out of the DJJ. So the first one, and we just want to highlight that we're just going to highlight them individually because we want to make sure that we provide the data, but also what we do, because this is numbers. I know it's one of my fortes when it comes to statistics. I love the numbers, the percentages, and how we get there. but a number without definition makes no sense. So whenever we're talking about our performance measurements, we also want to make sure that what does that mean and how does that translate and how can we make that number either stay the same or increase even higher. So some of the things that for school attendance, barriers and strategies. So one of the biggest things that I can say for sure that my CAT teams have accomplished, and I think this is a little bit more because I know for this fiscal year we have been up and above for making sure school attendance, making contracts with the school districts to make sure that we are engaging with the families and the schools at the same time. As per our last presentation, with our class presentation was an 87% of school attendance for all of our clientele within our Tri-County area. Some of the barriers: transportations, illnesses, refusal, suspicious arrests, hospitalizations from schools, runaway status, and zoning issues. So we did have a change in some of the school zonings for transportation issues. So some of the school buses that used to be in one area are no longer in those areas. So students just getting reallocated to where the school buses were actually. Now they have to take those school buses. There was some a minimal issue at the beginning of the school semester during that time. Illnesses, we have a couple of clients within our CAT teams that their caregivers are ill medically and they can't transfer their kids to school, which is one of our areas that we work conjointly with the schools to make sure that school can support and we can provide additional support within those spaces. Transportation, I know we live in one of the um, highly transportable counties, as I would like to say. We have a lot of transportation within Orange County, with some changes in just a few past months for other counties that I oversee. But transportation, even though being Orange County, I call it the center capital of and a lot of people coming in for Disney, Universal, and all these lovely areas. But we still have some difficulties with transportation, like bus transportation, the train. I was almost gonna call it a subway as if I was in New York again. But transportation is definitely one of those issues, and with the zoning for school buses also plays a big role for transportation. Hospitalizations and arrest mostly within the schools that they've been initiated within the school, and suspensions, but mostly out of school suspensions. And some level, some runaway status. We do have some clients that are runaway status and they've been posted. So there's also like in areas of significance because they're still under our caseload. We're still working conjointly with law enforcement or other departments to make sure that we support the family once the client gets back into the home. Some strategies, like I was saying, the number doesn't make sense if we don't give it a strategy. I mean, the number is there telling us a story. Let's give it a number. Let's give it a story. Let's give it a sense, and let's work conjointly. So, school attendance. Let's work with the schools. Let's work with the school and the family. Let's teach them what they can do and cannot do within the school district. What the school district is allowed or help them with. This maybe that the student might need an IEP. We might have a student that is recurrently getting hospitalized, going to a Baker facilities or going to a Marshman facility, and they might require something more specific for them within the space. Then maybe let's work with the family and teach them, hey, let's start working with the school to make an 504 plan or a IEP plan for that student to make sure that they're successful within that school. Facilitate some of that conversation within the school with the school principal, with the state coordinator, with the social workers. So we make sure that all of those areas also, and majority of the time is coaching the family as well, not just doing because as much as we want to, some schools and some districts might be the caregiver has to be the first person bringing that to our attention. So we coach the parents and the caregivers and the students to be able to have that conversation and show them the process of how that can look to make communication between the client, the family, and the student be cohesive, or at least be in a space that they can support each other. And I think that's something that, at least in our county, we within our three counties, Orange, Seminole, and Osceola, we have contracts within our school districts to actually attend and be in the school to provide some level of our services and also to participate within the IEPs, so 504 plans from the school district. And we have constant and frequent communication, at least monthly and quarterly, with the district and the schools to make sure that we are all in support of the families that we're serving. So it's not just one, it's all of us.
Yeah, and a word kind of about the schools and the specifically the IEPs and the 504 plans in just providing school in general or school services in general. The teams do a really, really great job with developing these relationships with the schools. I think it stands to reason, right, based on everything that we've said about CAT team that they takes a special kind of person. And so that being said, they are going in and they're most likely they're here for, they're not just here for 2 or 3 months and then moving on to the next job. So they are therapists, our case managers, they have the opportunity and they take advantage of that opportunity to grow these relationships with the folks at the schools, school staff, school faculty. So a lot of times, that input that we provide and the therapists and the case managers provide for the IEPs, for the 504 plans, those tend to be a very good, uh, really, really beneficial for the family and for the kid because, it's collaborative, right? So it's seeing things that maybe the school doesn't see. It's bringing to life maybe behaviors that are happening at home that the school doesn't know about, or vice versa. So it really is key. And again, they are the collaborative nature of not only the therapist relationship with the schools, but the case manager's relationship with the schools, because the case managers are going in every month and they're procuring school attendance. Sometimes they're collecting grades, things like that. So again, just driving home that community, that collaboration.
And something that I want to add that this year, we started a new initiative with Orange County, Seminole, and Osceola, where we're providing on a monthly basis a report from our end. So that shows them what things we're doing with the clients we're serving on our end, on the community, in the client's home. So there's a constant communication between the schools. They send us phone numbers. They let us know if anything's happening over there at the school. But we also let them know, hey, the kid has been attending X amount of sessions for counseling, case management, mentorship. If they attend groups, within our programming or outside our programming, if they have been attending for medication management, we report to the school, so the schools are aware where we are, and that's collaboration. And we do make sure that everybody is in the same page so that we all can work together, and it's not just school is doing one thing and then we're doing the other thing. It's everybody in the same boat doing the same things all together.
Yeah. So next is community integration. So we talked about making sure that these kiddos are in the community and trying to keep them out of higher levels of care, hospitalizations, Baker Acts, being arrested, all of those kinds of things. So for our organization, for Aspire, as a representative of Aspire, for last fiscal year, we did accomplish 97% of community integration by keeping these kids out of those kind of higher levels of care, from being arrested, from the child welfare system. And that is a huge accomplishment for us. And I think just across the board, as far as barriers to, accomplishing these kinds of numbers or any kind of, community integration in general are, arrests, like we've talked about, which a lot of the kids are coming to us with previous arrest history. That's just the facts. So arrests, physical and psychiatric hospitalizations, as well as child welfare involvement, like we talked about it. So some of the strategies that we utilize here with the Tri-County area are, again, the mentorship piece is so important, because oftentimes our mentor will hear things that our therapist hasn't heard from the kiddo. Our mentor might hear things that the parent hasn't told the case manager or hasn't told the therapist. And so, again, that collaborative nature of the team environment, as well as, coordinating those activities with the mentor. There's so many initiatives I'm sure that we've all heard of historically or even currently, of mentorship and, trying to keep kids off the streets and things like that. So that's no different with CAT team and the mentors that we have here on the team. We also plan events with our kiddos. So, over the summer, Orange Cat had a field day, and it literally was a field day. So we rented out some space at a park, and our mentor put together a bunch of outdoor activities. We bought some supplies, and the kids had a great time. They did foot races, basketball races, water balloon fights, all kinds of stuff. So again, not only is that integrating the kids, but it's also further integrating the kids in the community because we are at a local park. Everybody knows the park we were at. So again, we're sustaining those relationships and fostering those relationships. Kind of like what Lyanna said about, maintaining that contact with the schools. We're also, in contact with the folks at DJJ. If we have a kid who we know who the probation officer is, we always have a release of information signed at intake for all probation officers. If there's an open investigation, if there's a CPI, we always have a release of information in order to continue that collaboration. As well as, the local inpatient facilities, of course. I think at this point we're all on first name bases, as well as not just the facilities, but, with other community agencies like family partnerships, Children's Home Society, all of these different agencies who we are in contact with. And again, it's not usually a short-term kind of position that our staff, falls into. The folks that do come onto the team, it's a testimony to them in order to have that longevity, to want to build and foster and create those relationships as well with our community partners.
And to add to this one as well, and I kudos to Emily and her team and Stephen and also in Seminole County and Katie in Seminole and Osceola, is the partnership of sponsorships because we have limited funds. So that means that not all the funds are going to go into these activities. So I really want to shout out them because they go out and beyond to make sure they go to Publix to get some sponsorships from Publix. They can get some sponsorships from the parks to make sure these activities happen. So it's not just our funding, is the funding that we can get throughout the community. So it's that integration where we just not just give meaning to our program, but meaning to the community in general. Because when the community gives back to us and provides these sponsorships for these kiddos, we just had an event in December as well, where we were able to provide food to families. And I think we had an assistant about almost 100 families in attendance to provide services. And that was thanks to McGoey's Chicken. So they provided those feeding, and we actually had some of the staff donating their time for a picture with Santa Claus. So I wish I could share all the pictures, but some of them, they have climbed up in there. So we cannot share all the pictures, but in that sense, like we had that ability and we connect with the community and integrate across the board. And I think it just makes such a difference when we're working towards when we're working with the families. It's not just, okay, we're just going to do it for the integration of the community and making sure that our clients are not getting bankrupted, but also how can we integrate and get the other parties that are not necessarily stakeholders, that are not necessarily agencies or organizations, they're part of the community at large. Alrighty, so NICFAS, like Emily was saying, the North Carolina on your assessment. So this one's initially this assessment was geared towards child welfare. So we adopted it within our organization and we hit within our measurements a 94% of child well-being and diversion from the higher levels of care. This also says family integration, parenting, so a community assessment. So within all these, this assessment itself, we can see not just the micro of the individual, but we also see the macro of the individual. So we see them at different levels and different systems and how that dynamic is either interfering or in some ways improving. Because sometimes we have some areas that actually improve, like the academic aspect within the NICFAS assessment showcases what the schools do for the families. Within these numbers, I think some strategies that we take from is to build stronger communities, build that partnerships, not just from the systems, from the stakeholders, from the grant funders, also from the community at large in itself. There's many community partners that outside our stakeholders and our funding are available and at your disposal to go and explore other additional fundings. And I think in last year, I got just so much joy from seeing even like the aspect of seeing Publix being so grateful to know, like, here you guys go, and, have a fun time with the kiddos, go out there to the community. So it's not just here, we do this and that's it, but also connecting the families to be self-sustainable. I think that's another aspect of the next class, is to make sure that the family is self-sustainable, not just doing a referral or not just doing a linkage of service, but how to access that outside CAT team. Let's sit down with the parent, like, okay, let's do whenever next year is due for that reassessment, reevaluation for maybe SNAP benefits or for housing. What do you need and how do you access that and how to do that so you can be self-sufficient within that space? Because again, it's about sustainability. Yes, it's a measurement that we utilize, and also we want to make sure that it's a measurement that sticks to them and that helps them go to that next level within themselves. Alrighty, and the next one is our symptoms outcomes, which is our CFARS and FARS.
Right. And I think most of you are probably familiar with the CFARS or FARS. And so for this area, for the Tri-County area, for the last fiscal year, Aspire, we were able to produce a 95% success rate for, again, assessing these symptom stability via the CFARS or the FARS. Excuse me. And so what we are reporting on is that, right, there is the appropriate decrease of the CFARS after treatment, right? So some of the barriers that we have experienced as far as the CFARS, and if they don't increase, if they increase instead of decrease, are, those kiddos who, unfortunately get removed by child welfare, or they do have to go into SIP placement and things like that, or juvenile justice commitment. So sometimes we have those kids who, there is a program here in Orange County called OAKS. It's affiliated with Orange County DJJ, as well as, but it provides a lot of kind of comprehensive services, but from a law enforcement standpoint. So oftentimes we might lose kids from Orange Cat team who have to go to Oaks. So sometimes we may not see that their CFARs decrease, right? Because they're kind of just transitioning into a different level of care, a similar level of care, but with DJJ, right? But again, some of our strategies to kind of combat these things, again, mentorship. And you guys will hear me say this over and over and over again. Mentorship, collaboration, and teamwork. I think those are the heartbeats. If something can have 3 heartbeats, those are the 3 heartbeats of CAT team. So the mentorship activities and continuing to expand on what they're learning in treatment, whether it's coping, whether it's life skills, and again, that community integration, like about our field day and all the events that we have, those community organizations, or excuse me, those community events that we have kind of make you feel like you have a place. Maybe these kids are feeling like they don't have a place, but they do now. And then of course, like I was talking about earlier, we don't have to wait for TBOS authorizations. We don't, if we
I think so what Emily's trying to say is, oh, here we go.
There we go. Am I back? Oh, okay. Sorry about that. Yep, it's my connection's unstable, so I apologize for that. This never happens, but of course it would happen today. But yeah, so the additional counseling, if needed, if we have a kid in crisis or a child who is self-harming, but they don't quite meet the criteria for a Baker Act, we might say, okay, like the therapist and I might staff and say, yes, we should be seeing this kid more often. Go ahead and see this kid twice a week until maybe their crisis passes, maybe 2 weeks, maybe 4 weeks. So all of those kinds of help kind of drive down those CFARs.
So now we're moving into more so what we do, and I think this is where we're going to highlight some of the stories. We're going to try our best to read them as verbatim as possible. And these are just success stories across the board within our different counties. So we've selected just 2 stories. So this is a statement from one of the caregivers from one of the CAT teams. The CAT team was a blessing to our family. The therapist and the case manager were always also there de-identified, so you're not going to see names of specific staff and or clients. We're always available to help guide us through the difficult time. We're forever grateful for all their help. I don't think words can describe how much of a blessing the CAT team has been, not only for the individual, but our entire family. We were originally started working with them. I was worried that my son was heading the wrong direction. Little did I know how much our lives were going to change and all the health struggles my son was going through. My son went through various surgeries, including an open heart surgery for a mitral valve replacement, and the team was able to work with me and get him to open and express his feeling. And it's that in itself is a miracle because he rarely opens up and tries to converse with those, let alone express his own true feelings. This is one of those cases that actually was looking closely because it takes me back into my times when I was working with the CAT team directly as a therapist. And when I was working with this particular case, is the we were able to transfer them over to another county because they needed more medical assistance. Where in the Orange County, they were not being able to get that level of that care they were needing. So we were able to get them into another county, work with them and the other county CAT team to get that transfer over and work together and consistently to make sure that there was no interruption between one service and the other. And I think that highly speaks of our CAT teams and the collaboration we have within all of our CAT teams. I don't just see it in stories like this. I see it in our CAT meetings. We have monthly CAT meetings. We meet every single year for BHCon, and the camaraderie between everybody on the table of just talking about how precious our CAT teams are and how we are always in each other's back. And it doesn't matter if someone is in Leon County and I'm here in Orange County. If I need something and some level of support, I talk with Manatee County all the time. I talk with Lake County all the time regarding our CAT teams because it's the camaraderie that we have, that we share stories, that we see these stories from these kids that we serve, and it's not just a camaraderie like it's just here in our Tri-County area. This is just across all the counties, and I am so grateful because this case, particularly with the health complications, if we waited too long or too little, it might have been a different story that we were reading today. But just the transparency of one cat with the warm handoff from one cat team to the other. I'm forever grateful for the Hillsborough County cat team that helped us in this process. That was amazing. Client was able to get the medical care they needed within that county and continue cat team services in that county itself. Um, which again speaks highly volumes of different cat teams and where we all had the same shared vision and mission towards helping clients not get to the higher level of care and if need be there with them and support them through the whole process of it and not drop the ball on them and because most of these kids have had that happen to them so many things so many times and the families themselves have had these situations happen to them so many times. Majority of our cases come from several works through different systems and continuum of cares where they are just frustrated and having someone in their back, someone that's actually putting the time to listen and to be there and to not give up on the kiddo. Like this kiddo, the therapist and the case manager and the mentor were able to be there even through the toughest time when client doesn't want to talk to you and you're like, oh, this is so frustrating. The client doesn't want to talk to me, but they went with it and actually work through getting that confidence, that trust within that client to be able to speak and to talk about their feelings and to receive the help and the support that they needed at that time. And I think it speaks volumes, not just for this case as ours, but for all other similar cases throughout all the CAT teams.
Yeah, and just kind of another story. If you there you go. Oh, I think that was
Split in two. Sorry.
Yeah, they switched. That's okay. I so you can read the story on the screen. I don't have to read it to you, but I do want to tell you a different story because it happened kind of while we were putting this project or presentation together. As as I was talking about earlier, the field day that we had over the summer. We, again, with the community partnerships that we made, we were on our way. I went to Publix to pick up the food that, was being sponsored for our event. And by the way, it was a lot of food. I mean, it was a ton of food. There was so much food that I think every kid got to take food home, popcorn chicken and subs and cookies from Crumble. Anyway, I digress. So when I went to pick up the food for us, I panicked a little bit because the folks there said that the manager that my team had spoken to wasn't there. So they directed me to speak to another, manager who was in charge at the time. I explained to her who I was, gave her my card, what we were doing, what we were looking for, kind of the just the story behind how we got to where we are, and who we had spoken to and all that kind of stuff. So she went in the back and she said, she comes back out and she has a receipt. She gives me a receipt and she says, yeah, they're bringing out your food. She said, but I have to ask you, did you say cat team? Yes, I said cat team. The floodgates opened and she just started crying. And the therapist in me was like, what happened? Are you okay? Can I help? How can I help? Do you want to talk about it? And it turns out she shared with me that her daughter was a part of the Orange County cat team about 4 years ago. And her daughter had such extreme agoraphobia that she could not even imagine going to school. Leaving the house was just such a bear for this child. And now she is, after she was on the cat team, and she did spend a little bit longer than that 6 months on the cat team. She was here for about like 10 or 11 months. And after that, she was a completely different child. And this mom was so happy and so proud to show me photos of her little girl, who's now like 19, of her child who was dancing competitively and, performing in pageants and all of these things. And, she was just so tearful because she was so overcome with emotion that she thought, okay, cat team, my life with cat team is over. But here we are, we're in the community, and she can see us at her job. And she was so overcome and so grateful and so thankful. She must have given me like 6 hugs, and some extra juice boxes for the kids. So that was kind of nice. But that's just a testimony, to community, to collaboration, and to the work, that our teams put in on a daily basis, and the genuine and real impact, that these teams and this system of care is putting forth, and really just driving home. So that for me was it's better than any story that you can read on a slideshow. So I just had to share that, because it really just highlights everything that we've been talking about, everything the cat team is. So
So I'm gonna read this story real quick before we go into the activity itself. But this one's I actually participated in the process of this specific story right here. The cat team came into my home without judgment. I was really scared to tell them about the bug problem that we've been trying to deal with for the last year. I didn't want them to think I was a bad parent or that I had to call DCA to have my kids taken away. Instead, they brought it up to me and offered to help. At the end of the whole experience, um, the cat team helped us get a house fully treated bed box with continuous 1 year extermination services, helps us get a new bed for the whole family and a new couch, and still managed to see my daughter for her weekly therapy sessions until she was stable enough to manage her own emotions without such intensive help. At discharge, they made sure to link us to therapy services, medication management, extra case management services, and therapy resources to help the whole family. The CAT team not only changed my daughter's path, but they also improved the life of our entire family. And to all the three stories that we have shared, and our focus is always family. It's not just the client; it's the family as a whole. And I think it just is the predicament of all cat teams across the board. And if you go to any other cat team, you probably would have seen or heard stories from those other cat teams that it's not just us, it's across the board. Like we're helping the family as a unit because it takes a village to help clients to get to where they need to be and to get from point A to point B. You cannot just help a client thinking that they're going to be, self-sufficient, especially with most of the clients are minors. So they do require some assistance and support from their legal guardians. And I say legal guardians because we don't just have parents, we also have grandparents, we have aunts and uncles, we have family members that are not family members that just took over the kiddos into their custody. So we want to make sure that it's not just let's help the client, but let's help the unit in the whole. And I think that also when I was speaking to with Melissa Larkin, I think that was something that resonated with me on regards to the CAT team is that it's not just helping the kid, it's also helping the family when need to be. Moving into our activity, we intentionally left the activity because this presentation will be accessible for you guys to revisit again. We highly encourage you guys to think about these questions here and think about the stories, think about the strategies. How does that fit into your programming? I know not all programmings are going to be exactly just the same as CAT team, but I want you guys to think about it and to I like doing PDSAs is one of biggest things to do whenever I'm working with my teams is making sure that we do a PDSA and we talk about it and plan and see what worked, what didn't work, what could have been improved. So in this slide, we intentionally left it here for your references. If you want to continue sharing this is a no, I'm gonna keep this for me and I'm not going to share this with anybody else. Knowledge that is not shared is not knowledge. So for me, it's always take this with you, share it with your teams, share it with the community, talk about how to integrate in those 4 areas, those 4 aspects of what CATing is: school attendance, community integration, family functioning, and symptomology improvement. Those 4 areas. What could be something that you or your team can do? And we'll share some stories of what we've done, because obviously being a webinar, we had the limitation of being able to do this in a more open setting. We did it in BHCon last year. We divided it and it was really successful. We were able to talk and be more intentional when we were talking about what can we do? How does that integrate within the different levels of programming that we have? But I want you guys to take this with you. And that was the intention to leave this here, because I don't want it to just be, okay, let's talk about it and let's do a webinar and that's it. I want it to be intentional, leaving a question within what can you do within your programming? What can you integrate within your own programming practice, your client base, whatever that is for you, and bring it to your community. Let's do something and let's make that ripple effect. Those stories that we just read, that we told you guys, that we story told you. Let's do a ripple effect in the community. Advocate for what works and continuous reassessing to if it doesn't work, let's just advocate to change. Let's work together in that same boat, in that same mission and vision. I think moving from Massachusetts down here, I wanted to do this and wanted to continue doing so, and making sure that the ripple effects is not just a one state event, it's a nationwide thing that can happen across all borders. So the first one that actually, this is from prior BHCon, right? So we wrote it down. So when we're talking about school attendance integration, and we touched a little bit basis on that, it's increased consistent school attendance through shared ownership and practical support. Something that we did do here in Orange County was making memorandums of understandings with our different school districts. That was the first and foremost. Starting it there to make sure that we have partnerships with the schools. We want to make sure that we're on board with what they're saying, learning their language. I think that's also something that I've been talking about, learning their language, because the way we talk as counselors, as treatment providers is way different than what the schools talk or are in concern of when they're talking about their students. So that's why you heard me in the prior slides, I said students, because this is school. We don't talk about clients in the school system. We talk about students. I was a prior school psychologist, and if you brought it to my attention and you told me the client, I would think we're in the clinic, and we're not in the clinic. We're in the school setting. So for me, students makes a lot more sense when we're talking about the same language, talking about what is the priority for the schools. Transportation, bullying, anxiety, routines, all these other added components. How can we support your school with our clientele that we have here and translate that to your students? How can we be there for you? Co-create step of attendance plans. We usually use the Vanderbilt assessments to send over to the school teachers to kind of see what's going on in the schools. We share that with the psychiatrist, so the psychiatrist is aware of what's going on there. We get at least on a monthly basis, we get either 1 or 2 school reports that tells like, hey, this is one of the students that's been having the most difficult time attending, but their attendance has improved. That's where we co-create those step outs and we identify within that school and the staffing within the school, who is that person within that school that can give us that information we can provide that additional support. And sometimes it's even the caregivers themselves. So, and then the other one, I didn't, I said that one, see. Track progress with visual calendars. I know from one of our evidence-based practices that we utilize is called Match. And we do have a school attendance worksheet that we provide to the caregivers and to the clients. Their teacher signs up on them, and we can see them and if their school attendance is actually working on that end.
One of the things that we've actually seen here in Orange County is for those kiddos who have historically struggled with attendance and the motivation to go to school, if they know that their therapist is going to be coming to school that day to see them, more often than not, they are eager to get to school that day. So again, just a testimony to, relationship building, really, So. All right, and moving along. So next, the goal for community integration and sustaining themselves within the community setting. So increasing participation in community activities that support social connection and independence. So some of the strategies that we've talked about that we've implemented are obviously, right, we start with the client's interests and their strengths, not service availability. Again, scheduling shouldn't be a conflict. Mentoring, we're basing that whole strategy of mentoring, the whole idea of mentoring is based on the child's interest and strengthening their strengths and helping them to see their strengths as well, which will increase their self-esteem, which might help decrease anxiety symptoms, depressive symptoms, anger, all of those kinds of things. Service availability, again, by any means necessary, as outlined very clearly in black and white by DCF in our Guidance 32 document, by any means necessary. Again, we identify a couple of low pressure community settings, whether those are libraries, the Boys and Girls Club, the YMCA, linking them to volunteer services, things like that. Using warm handoffs. So staff attending first visit to introduce families, whether that's like within our counties. Oftentimes we may have kiddos who are moving from Orange County to Seminole County or Osceola County to Orange County. And so, trying to be as present as possible for those warm handoffs so they can see, right, and they can feel that collaboration and they can feel that teamwork, that community. And then, tapering support staff as the skills are increased, right? So maybe for parenting, if the parents have been adhering to, what their goals in parenting have been, slowly we can start weeding those services as, the positives are increasing. And so all of these things are just factors that build on one another to keep these kids in community and want to be in community.
I'm moving into our family functioning and symptom improvement. It's one of my, if not all my clinicians will tell you, I love this area. I love the family functioning and the family unit as a whole when we're talking about clients and the higher level of care when we're providing services. And, the goal is to improve them by reducing any stress, confusion, conflict that could arise. And I think that's where our teams and when we're talking in DHCon, that some of those things, like having those hard conversations of, hey, we're transitioning, how that's going to look like. What are some skills that you want to maintain? What are some skills that worked for you that didn't work for you? And how can we support you in that process? And I think in the whole essence of the system itself, when we're working with the families, reuniting with them, what worked for you? What is a goal that you want to continue to achieve? Because more often than not, the clients that we serve, by the time they are stepped down from services, that might look a little bit different because now they were sustaining themselves with an attached system and now they're not having that attached system anymore. How that's going to look a little bit different, but still maintaining the essence of what they learned through that process. Identifying, like I said, what's working, what's not working, what feels overwhelming, what might not feel overwhelming. We have some families that when we're in that process of discharge and transitioning, they are, oh, I don't want you to leave. I want you to stay a little longer. And we understand like that is that attachment that they grow into that to our programming and to our staff. But we also want to make sure that if that feels overwhelming, maybe we want to extend maybe the next 30 days so we can actually have a more appropriate warm up and they can actually attain the skills that they need and refocus themselves like, hey, you've done the work that you needed to do. Actually discharging a client from Brevard County from another programming, and the same thing happened. And I think it's just that the great job that we do, and the things that we do as clinicians, case managers, mentors, that we show the families what stability might look like. And we show them what things that they might not be seeing themselves. And once they get to that point, they get really attached to us, but we make sure that the attachment is a healthy one. Create clear and realistic expectations for each family member, reinforce progress weekly with strengths-based feedback. So we show them our assessments. Like, that's something that we show them, showing our treatment plan. Where were we at the beginning and where we are right now? Are we still at that same level of intensity, or has this decreased as we're observing it? Or are we the ones observing it and it's difficult because, parents, let's be honest. Like, when you work in the morning, you are in the go-go and you go to work, you got to take kids to school, and there's a lot of other added components. And it's sometimes difficult to stop for a second and say, oh, wait, how we were at the beginning and how we are right now looks so different. And that in itself is an overwhelming feeling, because some families, like I said earlier, have been in the system and have been in these type of programs for so many years that they're just used to this, the sound of this. They're not used to not having this sound anymore and having maybe a different radio station. And for them, that is overwhelming in itself, because I don't have that support anymore. So we provide that engagement, and we make sure that that tapers down nicely instead of just dropping the ball and just calling it a day.
And then, excuse me, finally, talking about symptom-focused skill coaching. So the overall goal, the overarching goal, the magic of the magic, right, is trying to reduce symptomology. But how do we do that, right? We do that by increasing skills and usage of those skills, not just at home, not just at school, not just in the community. While we may be more focused in one or more of those areas, it's, again, the bigger picture. So across all settings. So identifying one or two priority symptoms and impacting daily life. And, one of the things that our team asks at intake, we ask the kid, what are three goals that you have for yourself? And then we also ask that same question to the parents, what are three goals that you have? What are the things that you see that this kiddo needs, or the family? What do you think that the family needs? Again, teaching practical coping skills, right? Emotion regulation, grounding, problem solving, all of those things. But also, Lyanna mentioned earlier, match. Match has a different, for those who aren't familiar, it's a modular approach to treating depression, anxiety, trauma, and conduct type disorders. And the whole conduct module it's an evidence-based practice that's rooted in teaching parenting skills, and teaching parenting of challenging kiddos. And so, using that. So the teaching of the practical skills is not just limited to the kids. It's not a, here, fix my kid, I'm hands off. Because those sessions are done primarily with the caregiver. So again, coaching caregivers on how to reinforce those skills at home, practicing those skills in the real world situations. So whether that's community events that we have, whether that's at school, whether that's planning for a family vacation or a family function, any of those things. And again, the mentorship is key. Like that story I told earlier about the little boy who has a lot of thieves in his family. This was a real world situation. He applied what he knew to this real world solution, or real world situation of being in Five Below, and was able to show symptom improvement based on all of the resources given and all of the skills that he's learned. And again, of course, always fun community activities like the field day, any opportunity that we can, encourage the kids. And therapy is not all work, no play. It's okay to combine the two. It's okay to have fun in therapy and in a therapeutic setting. So, just the practical use and application of these learned skills in outings and events and varying other, social experiences that we are fortunate enough to provide to our kids and to our families.
Alrighty, and here are some of the resources. I know it was shared in the chat earlier before. Some of these links to some of these areas. My favorite one is a specialty treatment team maps, as I access that on a quickly, if not by daily, every other day. I am in this specialty treatment team map, sharing information and contact information for the other CAC team, FAC teams, FIT, MRT. They're all in this same one. Guidance document number 32, there's more to that. But there's always, every year we get an updated version of it. Usually it's just with written and making sure that the grammatical is up to date and up to par. Always highly recommended 98. Let's use this resource as one of the biggest resources for mental health crisis across the whole nation, not just Florida. So share that with everybody in your teams. We usually have a one sheet paper with all the contact information for crisis in the Central Florida area. We also provide a handbook to the families with all these phone numbers that they can reach out and actually have those services. Same thing with you will find more information on CAT teams within the DCF portal, as well as the MRT teams within the DCF portal. Just because, again, MRT is that added component that it's not necessarily part of our programming, but we work conjointly within our programming, at least in our Tri-County area, to make sure that if we have clients that need 24/7 crisis intervention, they can be provided for that. And then specialty treatment team maps. It's one of my favorite maps. It's really interactive, has the most updated information. So
This
I
is where
really.
This specialty treatment team maps is where you will find which one is tier 1, tier 3, and be
Yes.
able to kind of figure out which counties serve those populations as well.
And I think we're moving now to the Q&A. So I wrote a couple of the questions down. So I'm going to be reading them. And then we're going to be answering. We're going to try our best. I know we have until 3:30, so I want to be mindful of the time. So I'm just going to read a couple of the questions. I'm gonna start with one that I do want to address direct a little bit more specific. I know there were questions about if we serve clients that are on the foster care and are they eligible. That has been a conversation with the CAT teams regarding having child welfare cases within our caseload. That is still not a definitive. That could be in the future. That might create another tier for CAT teams. It's just that within our continuum care for the managing entity, we have different other services that do cater more so to child welfare. The only component for child welfare, I know foster care, for foster care, the family has to be residing within the county of the CAT team, and there has to be an identified legal guardian that would be working with us to work with with our program during a significant amount of time. I would say personally, I have had the situation where it could be successful if we had that sustainability of that kiddo being in a foster home for a longer term, rather than maybe a one night stay. Usually, I had a family that we were serving. They stayed for a good 6 months. To some extent, we were able to help them the best we could, but then the transfer happened overnight, over a weekend, so that kind of interrupted CAT team services. And then the other question that kind of was with that.
I'm sorry. If I can jump in and add something to that. So, just the idea of collaboration again, because you guys know me at this point. But we actually have a kiddo on the team right now who is in foster care, and we've been working with the dependency case manager as the legal guardian, integrating his aunts with whom he lives currently. Everybody has been pretty responsive, pretty active in treatment. The dependency caseworker has not been able to attend one or more meetings. So we did have to cancel them because our psychiatrist, obviously, you can't give medical consent for a child that's not yours. But speaking to kind of the transition process that Lyanna was talking about, they are in the process of transitioning to Lake County. So we have been in contact with Lake County and trying to collaborate and see what the best course of action is in terms of getting him transferred. So it is possible. It's not a no if a kid is in foster care. So we definitely have that capability as long as all of the factors are there and we're able to provide the services and have somebody agreeable and able to make those decisions on behalf of that child as their legal guardian.
And within that question, I know there was asked questions, and kind of added that question, this next question to with another question that I saw later on. Are students with intellectual disability and or autism could participate in services? Unfortunately, because we don't provide behavioral ABA type of services, we primarily focus on the mental health and or substance use treatment portion of it. We're unable to treat clients within the spectrum. I'm not saying that other CAT teams have tried, because I think we all share that we at some level of capacity have tried to work with this population. It's just the training that requires to provide inadequate treatment for kids without autism or intellectual disability does require another level of training and qualification within our staffing. Most of our staff are either clinical social workers or mental health counselors or family and marriage therapists. So they're not necessarily they have the training to be able to be the best providers for these members. And I think it's across all the CAT team, because the requirements for a counselor within mental health counseling or clinical social work, not necessarily someone with an ABA background. So that will be something that will be an exclusionary criteria, but we do work frequently with those families, and we provide the actual resources that we have here in our area to make sure that they are linked to those services. I know for our area we have APD, Agency for People with Disabilities, and we also have Zebros that does oversee those type of symptomologies, and they do take care of those clients on their continuum of care, and we link the families to those services. We don't want to. For my always thought to that is I don't want to leave a family that are in need of services without the resource. And we have a PDF document it's an extended PDF document with a lot of resources for these type of families that they can actually benefit from, and they can reach out and provide those to, like, if anybody has reached out to me regarding this, they know I share that with them and I send that PDF, and it hopefully is helpful. But to expand to that and making sure that it's not just okay, let's keep it there, but let's expand and advocate for maybe more services within the community for for these populations. I know that was another question about respite services and adults being in the home. Obviously, per HIPAA, we are required to have an adult within the home to provide services. That could be the legal guardian, or that could be someone that the legal guardian has appointed, and we have a release of information for that person to be there presently. But we cannot serve any client. We cannot see clients that are under the age of 18 without adult supervision. Obviously, as per legalities for that. So if someone is working with us and they need and for example a parent needs to go to work and they leave their kid with their significant other, we make sure that we have a release of information ahead of time, that we can have some adults. Sometimes we have grandparents within the home, making sure that we have that added component of that release of information signed prior treatment, so we are all covered in all areas.
Right.
Not sure if you want to add something else for the respite services and the adult presence in services.
No, not really. Just that we will, if true respite services are needed, that is something that, we can help link the family to, and obviously keep in touch with them and, monitor them, and even still provide therapy services while that kiddo's in respite, as long as it's within the county.
And I think I want to share this. For the there was a question about the RIs. How does that work for us? So this is actually something I brought from Massachusetts for myself, and actually implemented it within our CAT teams here in Seminole, Orange, and Osceola. We do a lot of RIs, and I'm not saying like, oh yes, we do all of them because we want to, but we want to make sure we have sufficient RIs laying out, especially for crisis situations. So if we know that we have Central Florida, UBC, Park Place, all these other agencies that are working with us for Baker facilities, and the parents have to take their kids for a Baker Act or a Marshman Act, we don't want it to feel rushed that it had to be signing off a release information in the midst of the crisis. We preemptively, by intake, ensure that all of these RIs are pre-signed and in our charts, so that way when we need to maybe reach out to the Baker facility to get some paperwork and documentation, we can do so without having too many caveats and too many difficulties reaching out to the family and the parents. When we're working with them, it kind of alleviates that added layer, because we just want to support the parents. We don't want to hunt them down for a signature so we can get some release records, or that we can attend the discharge meetings and stuff and such and such. Anything you want to add to that one?
No, just that. I mean, I think it also was really helpful, like not only in the, crisis world of, hospitalizations, but also like when a kiddo gets arrested and, all of a sudden, tomorrow they're assigned a probation officer. We already kind of are one step ahead in being able to access that person or information regarding our kiddo.
All right. So I know we had a couple more questions, but I want to be fair of time and I want to be conscious of the time. So if anybody had any additional questions, we do have our contact information in the next slide if it wants to move. There we go. That you can send those lovely questions our way. We'll be glad to answer them. I do have like the question for what can case managers provide when stepping down from SIP? I would really love to answer that question. And average time of wait list, of course, send those questions over. We'll be able to share and answer those questions. Again, you guys have my contact information, Emily's contact information, and thank you so much for having us today. And I hope you guys all enjoy the presentation.
Thank you all. Have a great day.
Thank you so much, Lyanna and Emily. I really appreciate your time today and all the valuable information you shared with us. Again, their contact information is here on the screen. If you'd like to take that down, if your question did not get answered, or if you have additional questions you think of after the webinar, if you need their contact information, you can always reach out to us as well at FATA and we'll connect you with them. Please hold just a moment for a couple of conclusion business items. The evaluation will automatically populate when I end the webinar here in just a moment. You will also receive an email with the evaluation link in 24 hours. The evaluation deadline is next Monday, February 16th, 2025. If you need assistance or have any questions, you can email us at training@floridabha.org. Quick aside, I did see one question saying, do we have future CAT webinars planned? I know at FATA we do not have any on the calendar. Emily, Leon, I'm not sure about you guys, but I do want to say there is an optional question on that evaluation to suggest future topics. If you enjoyed this webinar, if you want to see Lyanna and Emily do a future presentation or continuation, please let us know as we begin to plan our next fiscal year's worth of topics. That information is critical to have. So if you want to see more CAT webinars, please let us know in that evaluation. Certificates will be emailed to the email address you used to register for today's webinar within 30 business days. CEUs will be reported to CE Broker within the same time period. You must have attended the entire webinar and completed the evaluation to receive a certificate in CEUs. We are not permitted to provide partial credit. As a reminder, the recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording in PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. Thank you everyone for participating in today's webinar. Thank you again, Lyanna and Emily, for your time. We'd also like to recognize and thank the Florida Department of Children and Families for funding today's education. Have a great rest of your afternoon, everyone, and please hold for the evaluation.